Okay, good morning, everyone. Time to get started. We have a very, very special treat this morning. Of course, we're celebrating our third annual Global Surgery Lectureship. Before we get going, I have to thank David Kuyama, who has gone on to a leadership at Dartmouth, who worked with Yihan Lin to start this, and also Kathy Tuttle, who has worked so hard in front of the scenes and behind the scenes to get everything set up. And before I introduce our very special professor, I also want to point out that we have two visiting doctors with us, Dr. Maurice Musoni and Dr. Dion Umalisa. And they are both visiting from Rwanda, and they will be accompanying us to the operating rooms and to the wards. And can you stand up so everyone can see you? Yes. Dion also, so turn around, yep. So if you see them and they look a little bit lost, wandering the halls, help them out, okay? And point them to the clinics or to the operating room. So very welcome and enjoy your stay here. So Dr. Sherry Wren is Professor of Surgery and Director of Global Surgery Center at Stanford. And she's the Vice Chair of Professional Development and Diversity. As important, I've known her, I think, for about 25 or so years. We've served on many committees together, and she has been a leader in several organizations of which I've been a member of. She did her undergraduate training at Carleton College, her medical school at Loyola. She did an HPB fellowship at UCLA. She's completed many, many other administrative fellowships. She's a member of the World Health Expert Panel on Surgery and Anesthesia. She serves as Director of Clinical Surgery at the Palo Alto VA and also Chief of General Surgery. She has won really too numerous to count awards for teaching, international programs, and work on DEI. And you know, I reviewed her CV this morning, and there are just pages and pages of awards. And I've never seen anyone with more teaching awards than Dr. Wren. She's been president of the Halstead Society, which is a society that has visited us and very dear to me. She has led many other organizations, including president of the Northern California chapter of the F.A.C.S. She is president-elect of the Pacific Coast Surgical Association. She's been the PI of many grants and has mentored many surgeons in training, including international surgeons from around the world, obviously. She has 167 peer-reviewed publications. She's really one of the most interesting surgeons in the world and definitely beats that guy on the Dos Equis commercial. I mean, I had dinner with her last night and it was nonstop story after story about this war or being on a sunken ship or, or being on a ship that was sinking or just battles with medicine. She's really made a difference, has served in countries of need, both in war and in peace. And we give her a warm welcome this morning and look forward to the talk on education and training of surgical workforce, a solution for the global surgery deficit. Dr. Wren, thank you so much.
Well, that was quite an introduction. I'm really honored to be here. I'd like to thank Dr. Schulich and Dr. Lynn and Ms. Tuttle, who I've worked with for years with Halstead. So this is going to be a bit of a journey. I've had, I would say, an interesting career. My career in global surgery started in 2006, when I decided that I was going to volunteer to start working with Doctors Without Borders. And because of my high school French, I was able to go and work in conflict zones in French-speaking Africa. That was my introduction really into global health. Not really done anything before that. I'm a GI cancer surgeon at home, robotics, and this was sort of about as far away as one could get when you're sitting in the middle of Chad. I then sort of moved on to try and make this part of my academic life. And this is going to be sort of a talk not really about global health, but sort of what's the state of the world right now and looking at our surgical workforce. You know, there's a lot of, I think you just see, there's massive global population increases. Up until COVID, life expectancy was increasing every year. There's finally been recognition that surgery has got to be part of every national health plan. If you're going to have the health of a population, you have to provide surgical services. I'm a prime example of the aging surgical workforce. I am closer to Medicare age than anything else, and that's true across America right now and the world. Preferential distribution of our workforce, it's really hard to get people to want to go work in rural areas, whether it's here or abroad. And in many low middle income countries, you have this outmigration of people getting their training and then moving to other places. How could I complain? My grandparents moved here. I mean, that's just part of life. People move. And sort of what I'm going to begin to talk about is this whole rise in the non-communicable diseases. If you work in public health, they speak about NCDs all the time. And these are things as surgeons that we take care of. This is diabetes, cardiovascular, all these things. And when you look at the total number of deaths from 1990 moving forward, as we have gotten better at treating infectious diseases, diarrhea, pneumonia, HIV, all of these things, children are dying less, people are living longer, and now you see the rise of the NCDs. What's really interesting is that injury deaths really haven't changed much. Injury just sort of stays this steady stream. Personally, I think about injury as also a non-communicable disease, but public health people don't. As a cancer surgeon, it is amazing to see as populations age, of course, people are going to get more cancer. And the global burden of cancer is exponentially rising. And this data was just actually published. This is the risk of premature mortality from cancer. And when you look at the countries that are in the red and orange, those countries are disproportionately hit by premature deaths because of lack of treatment for cancer. And what's really amazing when you go and to a lot of these things, you'll hear them talk about cancer treatment and they talk about chemotherapy and palliative care. And you're like, wait, what about surgeons? We cure more people of cancer than many other treatments. So trying to just get surgery onto the map for cancer treatment has been a battle. So this impact of these non-communicable diseases, you can see is disproportionately shared by income of your country. So in high income countries, yes, we absolutely have people dying of their cardiovascular disease and all of these things, but the impact is much higher in low income and low and middle income. And it really exceeds the gains that were made by controlling infectious diseases. So this increasing demand based on non-communicable diseases kind of translates to something like 10 million cancer deaths last year, most of them in low and middle income countries. The incidence of cancer is expected to rise more than 90%, both in the last year and then in the next 20 years. And when there is the estimate of how many procedures, how many surgical procedures does a population need to sort of address this global burden of disease, it's about just under 5,000 procedures for 100,000 population. So everything in public health is always this per 100,000 population. And you can see the breakdown there that the vast majority of these are needed for these non-communicable diseases. And just fairly round numbers for both communicable. I mean, think about, we do a lot of sepsis surgery, abscess surgery, infectious surgery, and also for injuries. So this surgery specialty workforce is really a national, international problem. And what I want to introduce is, all of us know is that we do not stand alone as surgeons, right? It actually takes a whole team to go to the operating room. And what we also really have to have is our anesthesia colleagues and obstetrical colleagues for the health and welfare of a nation. So if you look at using maternal mortality as a surrogate for how many specialty workforce in surgery do you need, what you see is that when you hit a workforce density of 40 surgeons, anesthetists, and obstetricians per 100,000 population, you really see no more benefit in having more. So many countries have more than 40, but you've now sort of evened out that benefit. So reaching 40 is a goal. You can see if you hit 20, you're finally at that steep part of the curve where the vast majority of countries now have achieved sort of this flattening of maternal mortality. So this density of this specialty workforce, this SOA workforce, is really directly related to your national health. Unfortunately, only about 12% of this workforce works in Africa and Southeast Asia, which is about 30% of the population. And less than half of the world actually lives in a place where you have access to this degree of workforce. So the Millennium Development Goals were put out in 2015. They were audacious goals to try and really say by 2030, we will have changed things. And one of the Millennial Development Goals was that by 2030, we were going to have a minimum of 20 of this specialty workforce per 100,000. And in 2015, it meant that the workforce was going to have to double. That was unachievable. And you can see here on this map, this was actually published a couple years ago. If you're in the green here, you have more than an adequate workforce to reach this goal. But the countries that are, I guess, kind of either very, very light green or the yellow really have a huge way to go. So how can we do this? Well, there's a couple of solutions. We're going to talk about task shifting. We're going to talk about increasing trainees and increasing the percentage of women in the workforce. So this was some data I put together a few years ago that looked at a number of African countries and kind of mapped it against the United States. This is all surgeons, ENT surgeons, orthopedic general surgeons, and there was only a single country, which was Kenya, that had more than one surgeon per 100,000 population. Whereas in the United States, we're close to 45. The estimate is for a population, you need about 6 general surgeons per 100,000 population to be able to take care of them. I think people never really understand how large Africa is as a continent. So you can actually put the land mass of the United States, Europe, India, and China on it. So when you look at a deficit from a continental standpoint, Africa really is has a significant deficit of this workforce. So now I'm going to talk about probably one of the most controversial topics you can get into, which is task shifting. This was defined by WHO as this rational, it sounds great when you define it, it's a rational redistribution of tasks amongst healthcare workforce teams. You take it from highly qualified people, and then you bring it down to less qualified people who had shorter training. This can be applied to both what we call non-specialty MDs, so general medicine doctors, or associate clinicians, which is what we call now APPs or mid-levels. So believe it or not, around the world, non-surgeons and non-physicians provide a large amount of surgical care in some locations, including more than 90% of the operative obstetrical care and 40% of general surgery and non-OB laparotomies. So the first time I was working overseas in a conflict zone, the person who taught me how to do a C-section was actually a nurse, because when conflict happens, people leave, and oftentimes physicians have resources and they've left, and who's left behind are nurses, and they are doing operations. So this is a fairly recent systematic review on the global use of what's called associate clinicians. So for us, that would be nurse practitioners, PAs. They've got different names in different places in surgery. And you can see on the map, if it's a white, there's no data. But in North America, we widely use associate clinicians surgery. We have nurse practitioners in ICUs, placing lines, all sorts of roles, minor procedures. In Africa, the countries in yellow actually have governmental rules that disallow this, but then there's a huge amount of Africa that actually uses this for surgical services. Anesthesia task shifting is much more widely applicable across the globe, except it's interesting that in the purple countries, they also do not allow task shifting of anesthesia. So I'm going to take you through a shocking example. Mozambique. Mozambique was a conflict country in the 80s, and they're a very rural country. So they designed this non-physician clinicians. I do not speak Portuguese, so I'm sure I'm going to murder this. Técnicos de Cirurgia. And they were doing about over 90% of the OB and major general surgery in district hospitals. These are non-MDs. They're mostly mid-level practitioners or nurses. They live and work and have experience in the rural areas. They undergo training, 2 years, and then a year of internship. You could do this job right out of high school, believe it or not, or you could have a nursing degree. What's critical for a lot of these task-shifted surgical workers is that they stay in their area. They will actually stay in the rural-based area, where in many areas, physicians will leave the rural areas, just like they do here in the States, to go to the more urban distribution. So just to put in mind, this is a 1-year data of 14 of these technico-surgicos. Look at the operations they did. So here's emergency surgery. Not surprisingly, they're doing a lot of C-sections, soft tissue infections, but also appendectomies, splenectomies, colostomies, and fracture management and drainage for burr holes. Emergency elective operations, hernias, a huge amount, tubal ligations, even salpingo oophorectomy. So this is a fairly wide range of surgical activity, not just a general surgeon. They're doing orthopedics, OB, urology, and with very few complications and really respective mortality figures. So this was reported in the WHO bulletin a number of years ago. Another example of this, another conflict setting, basically in Somalia, Doctors Without Borders set up sort of practice guidelines and then trained a non-surgeon MD. I'm not sure anybody here is old enough to remember when family medicine doctors used to do hernias in the United States or in Britain, but they did. So non-surgeons have done procedures before, and they also trained a nurse. So when the conflict got too hot and it was too unsafe, the expat surgeons and staff left, leaving the Somalian physician and nurse to do all the operations. The nurse performed almost half the C-sections and more than half of the uterine evacuations. And you can see that the mortality rates did not really change. Okay, that's great in conflict. Okay, what about any other thing? So this invited commentary I wrote a number of years ago, I'll show you the data of the paper that we wrote this commentary for, was meant to be very provocative. It actually made me the most hated surgeon in the United States, not once, but twice, because it was first published online and then it came out in print. I cannot tell you how vilified I was on various platforms, the American College of Surgeons communities. My dean, my chair received letters about how could they let this horrible surgeon here be at Stanford University because of the opinions that I expressed in this commentary, and they are opinions that I stand by, which is I actually don't believe that it's the initials after our names sometimes. I believe it's our competencies. And I truly believe if we could design our healthcare differently, we would train people to do certain procedures and keep others for more specialty trained. So this was the paper. So basically this group took a group of medical doctors and surgeons in Ghana. It was a prospective study. It was done very well, which is why it got published in a JAMA network. They did a formal training in Liechtenstein anterior hernia repair with mesh. They used competency-based assessments, the American Board of Surgery tool, and they basically couldn't proceed unless they could show competency. The primary outcomes here was hernia recurrence at a year. Secondary outcomes were post-op complications and patient-reported outcomes. So you can look, there's really not any difference here in these patients. And in Africa, because the burden of hernia disease is really left untreated, almost every hernia is inguinal scrotal. Here, each group had more than 50% of inguinal scrotals. Here's the outcomes. Hernia recurrence rates. Believe it or not, the medical doctors did a bit better, significantly better. There was no statistically significant differences, though, in complications, satisfactions, chronic pain, or self-assessed health by the patients. What did this show? It showed that you could train people to do anterior hernia repairs and have a high degree of patient satisfaction, and kind of lends credence to the fact that you could do task sharing to alleviate some of this global burden. This group has gone on to do this. This is actually a different group. This is a group out of Andreas Vladis. He's been working in Sierra Leone, training these associate clinicians for years because, again, it's a post-conflict country. They don't have enough surgeons. They have like one surgeon for like more than 1 million people. So this time they took medical doctors who have also been trained and compared them to their associate clinicians that they train. And once again, proved conclusively that non-surgeons can perform very well doing inguinal hernia. So how are we going to incorporate this in the United States? I don't know. I think we should. Strategy number 2, increase training physicians. So many low and middle income countries are expanding medical school and class sizes. And it's really difficult because they literally go from like, we have 100 students to 300 students. It doesn't mean that they have more faculty though. So how do you handle this huge influx? You know, training programs require structure, curriculums. I think this is a huge opportunity for partnerships with academic institutions in high income countries to really help with this because there's a huge need here. Kind of the path in Africa, basically you go to high school, you take some exams, then you go to medical school and do an internship. This is about 5 to 7 years, depending on what country. You then register with the medical council. You are now able to go and work independently in countries now. So to apply back, so you could go out and be earning money. So to get into postgraduate training for surgery or other specialties, you now have to apply back. And believe it or not, you have to pay for that training most of the time. So you pay to be trained as a surgeon. So this is one of the barriers. There's also limited opportunities for this postgraduate training. And unfortunately, to achieve training, about 20 to 40% of graduates leave the country. We heard about how our guest here had to leave his own country and go to South Africa to get his training in cardiothoracic because it wasn't available locally. Surgical training is still very unregulated. When I was invited to Vietnam, surgery training there is anything from about 3 to 4 years. So in Africa, training is really governed by the colleges of surgeons. The 2 oldest colleges are the South African and the West African. And then I'm going to talk a lot about the College of Surgeons of East Central and Southern Africa, COSEXA. I have to disclose I'm the North American representative to COSEXA, so I might be a little bit biased about COSEXA. But their entire vision is to basically enhance surgical services in the sub-Saharan region by increasing the number of trained surgeons and surgically trained general medical officers. So in their vision statement, they also embrace some of the task sharing. This has been a great place for academic partnerships. This is a 14-country consortium throughout this EXA region. This is really set. They want to increase the ability of surgical services, especially in rural Africa. This is sort of an all-encompassing organization. We have 3 organizations that do the work of one college. So they're sort of like the American Board of Surgery, the ACGME, and the American College of Surgeons all in one. So they control residency curriculums, examinations, and certifications. And there's 2 levels of certification. This MCS is after 2 years of training, and then they can leave and go and work in hospitals. So what's most important, the vast majority of their graduates stay within Africa, and a commitment to gender equity and surgery in the region. So this is a bit of their timeline. They started in about 1999, they had their idea. By 2006, there's about 500 surgeons in this area, which has a population at that time about 250 million. You can see the increases by 2016 up to 1,600, almost 1,700 surgeons. This is still a ratio of less than one surgeon, though, per 100,000 population. And they have specialty training programs in all of the surgical specialties now, and programs in 20 countries. So this is from a recent publication about COSEXA. So you can kind of see the map. The dark areas are where those are the constituent countries. And then the yellow ones are other countries that have programs with them. And Madagascar has now joined. So this is really taking over surgery in this entire region of a massive continent. A number of years ago, they had this great mapping function. And what you can see here is two countries, Tanzania and Ethiopia. So in all of Tanzania at this time, they had 181 surgeons. That's every type of surgeon, orthopedics, et cetera, for a population of 50 million people. You have more than 181 surgeons in your metropolitan area here. So imagine that. For Denver, I looked it up, it's about almost 3 million metropolitan area. So a country of 50 million has the amount of surgeons you have in Denver. Ethiopia is a very large country, and they had 400 surgeons for a population of just under 100 million at that time. What I really like is that you can then look at the number of women who are in this and percentage, and kind of illuminates how increasing women in the workforce can help solve some of these deficits. So this was the slide that was just presented to Executive Council showing what the program entry is. And you can see in the beginning, very slow, but now huge amounts of really massive growth for this area. You have to build residency programs and certify them. And these are the entry, and the insignificant growth in females coming into the profession, and growth by year of their graduates, to the point now where we're graduating more than 500 trained surgeons to enter into the workforce into this area. It's an incredible accomplishment by this college. They also established the Women in Surgery Africa group. It's an affiliate in 2015, and that's exactly when you see the takeoff in women coming into surgery in this region. The president is a member of the council, and this is really to support female surgeons and mentoring within the region. So you can see at 2015, the inflection of this curve. I can tell you that I started going into Zimbabwe as part of an academic agreement, I think in 2012. I was the first female surgeon that the medical students had ever seen. And it literally had the effect that women now were like, oh, wow, it exists, I can do this. They actually started a surgery interest group society called DREAM, because they had no idea that you could dream to be a surgeon. So these types of groups do have a significant effect. Here's just sort of a kind of history of COSEXA shots of the council. The American College of Surgeons and Association of Women Surgeons now sponsors a scholarship for women to be able to travel to take their examinations. I've been through many of the COSEXA countries. You can see there's some pictures here from Sudan, meeting with people, women. There's very few women surgeons, but who are interested. And my proudest moment is the lower, I think that's right hand, when I received the inaugural She for She Award from the Women and Surgeons of Africa, from the support given to trying to increase representation of women in this region. So what I really would like to sort of emphasize is that the engagement of women has to be part of this plan to increase your workforce. And this was at the Women's Leader of Global Health Conference, and it's always amazing. I can't tell you how many firsts I know. So here's Dr. Claire, here's Karakizi, who's the first neurosurgeon, female neurosurgeon in Rwanda. Dina Bakali is the dean of one of the medical schools in Rwanda. Dr. Mumba, who I've known for years when she was a trainee. She's the first female urologist in Zambia. Kat Chu, who's actually American, but has been living in Africa for years, was the vice president for Doctors Without Borders in South Africa, and a good friend, Elman Stein, who is the chair of surgery in one of the programs in Cape Town. All of these women really serve as a beacon for other women to kind of come into the field. So is this just a global South problem? It's not. So in the United States, we're facing a massive surgical workforce deficit, especially in general surgery and some of the other specialties. This was a report just put out by the AAMC. If you look at that graph, we are going to be in a 50% deficit of what we need by 2034. And you see sort of this change where many people now, this was just data up till 2016, the amount of people seeing physicians now is going down. So physician-only visits has decreased, APP visits have increased, and you're seeing we are task shifting healthcare away from physicians in many ways because of these deficits. Here's the breakdown by the United States at this point in time. You can see in all specialties, women make up about 36%. And in surgery, general surgery has the highest amount of women, but still, medical schools have been more than 50% or equal 50% women for years now. We still have underrepresentation of women in our workforce, and we have this big deficit of surgeons. Orthopedic surgery there at the lowest. Here's 2019's residents and fellows. General surgery is approaching, I would say, gender equity, and orthopedic surgery is still very much lagging behind. We must engage our students to come into our field if we are going to have enough surgeons. So how about access to emergency general surgery? So every red dot there is a hospital in the United States that can do emergency general surgery. It was really surprising to me that just under a third of hospitals could do emergency surgery. There's a lot of specialist hospitals out there we don't think about. Orthopedic hospitals or other, ophthalmology hospitals. And this really showcases in the States disparities. There's less access if you live in a minority, rural, or lower socioeconomic county. And if your county is predominantly Black, you have an 80% less odds of having an emergency general surgery hospital than if you are predominantly a non-Black county. So again, huge deficit in our own nation. So let's look at your little four corners, large four corners, it's not little area here. And what do you see? So this is data that the American Board of Surgery just released this data. You can go on and they have a big public release of data. So this is that four corners area. You can see the urban centers have the largest distribution of surgeons. Here's the male, these are ABS certified general surgeons. Here's the male distribution and here's the female distribution. So you see wide swaths of area with no general surgeon available. Again, we need to increase our own capacity here. Is this a US problem? No. Britain, they have huge shortages. In 2018, 12% of their surgeons were women. By 2020, it's now 13%. Again, not really growing, and most of them are in pediatric, ENT, and plastic surgery. Germany, same problem, 21%. You kind of see this 20% number. When I entered surgery, it was 4%. So have we made huge gains? Yes. But that was 2018, 2017 data. Germany now just over, still not significant gains. And that's when med school is predominantly female-based. So we're just not attracting people into our specialty. Why? There's a significant amount of barriers. There's just discouragement, perception about family issues. This whole thing, to see it, to be it. I actually have to say I've never understood that. I had never seen a woman surgeon. I decided to be one. It was all based on male mentors. But it's been shown in fields that if you reach this 30%, the field appears not to be male dominated and more women will come into it. There's a lot of stereotypes and conscious and unconscious bias. Japan is probably the most egregious example of conscious bias. So they have the lowest percentage of female doctors of any nation. 5% of their workforce is female, and they are going to be the oldest society by 2035. And of course, you need more surgical care as you are older. And what was really amazing is that they got caught in a huge scandal because most of even their most prestigious medical school, were basically taking the entrance exam scores into medical school, which is how you get your spot. And they downgraded women's scores because there were too many women that were scoring higher and they wanted to keep them actively out. That I would say is overt bias. So there's a lot of barriers. And I give your chair a lot of credit. I know that he's really done a lot of work to erase this. You have a lot of female faculty here and female trainees. But there's still a lot of issues. Women really are less likely to be included in a lot of things: research, informal mentoring, giving advice, and sort of these whole, it's a perception. Everything's always going to be a perception. They feel work is unsupportive, unclear rules of advancement, culture, and opportunities. Is this a problem? Well, it's really interesting. So is this all in our minds? So this was an economics paper. It's fascinating. It used US medical referral data, and it looked at whether primary care physicians react to good signals differently if the surgeon is male, or in bad signals if it's female, the surgeon is female. So it's really interesting. If you have a patient death, referrals to men do not change. And for those of us who do high risk surgery like Whipple's and other things, I mean, we have, virtually you do have some deaths sometimes. If you're a male surgeon, that's okay. If you're a woman surgeon, it's not. And what's really interesting is that if you have this perceived good outcome, referrals double, and they actually mapped their data. And so you can see here the after death event, referrals just dropping. This is off of US healthcare data. And that unexpected survival event, men's go up. So we still have perceptual issues. So how do you fix this? That's a whole different talk. So this meta-analysis or scoping review just sort of came out that looked at, is this based on this whole female thing? Is it based about your geography, your income level, cultural beliefs? And they did a review. I'm going to kind of just go through this pretty quickly. There's a lot of career challenges: ineffective mentorship, gender stereotypes, sort of the unclear expectations, this perceived lack of belonging, sexism, and work and family conflicts. Those are really the ones that were reported in high-income countries. In low-income countries, a lot to do with workload, family, the lack of women, seeing women in surgery, lack of role models, and a huge thing about cultural and religious beliefs. So Pakistan actually has one of a huge amount of women in medical school, and there's this whole thing about a doctor bride, and then because it's very prestigious to marry a doctor, and then women will leave the workforce. So there's a lot of cultural practices that are actually make some of this more of a challenge. Residency and training sort of comes out as one of the biggest areas of improvement that we could all focus on, both here and abroad. This negative stereotyping, exclusion, types of harassment. The really sad thing is that in almost all the surveys, the perpetrators of this are really male colleagues, and the majority of which are attendings. I think now in the States, there's also a whole thing where we're now seeing that this is also our patients in many ways. Medical students, believe it or not, still get told that women shouldn't be surgery, and they hear negative comments about women surgeons. So that's us in upper middle class. This was shocking to me. So this is a report out of South Africa. A third of women surgeons experienced physical threats and were bullied, which is really kind of shocking. These things happen less if you have departments with female faculty. And again, this perception of discrimination by staff, colleagues, and senior people. There's also a perceived difference in surgical skills and aptitude. This whole perception that women are less physically capable. I think this really plays in some of the fields like orthopedics. But I mean, a power drill is a power drill, right? And believe it or not, they did this study in this one low-income country, and both women and male believed that women were physically and mentally weaker and therefore less able to perform surgeries. So some of this is against self-perceptions or perceptions, unconscious bias or conscious bias can go both ways. Data actually shows, this was done here in the States with CT, that the gender trainee mix actually affected the scoring of different residents. And a lot of people know that letters of recommendation by which we base our entry into our training programs, there's huge gender differences. Actually, there's a website you can go to put your letter of recommendation in to get to see how gender biased your writing is. And if it's a letter for a man, it's 4 times more likely that they will have talked about their research, their publications, and they're longer. Women, they talk about personal life. They're a good mom, all these things, and give these sort of assurances like she could do the job as opposed to they're a superstar. So all of these things sort of change how these letters get read. And believe it or not, if you say that a woman is caring, compassionate, and helpful, which gets put there all the time, it can evoke this gender stereotype that actually ends up hurting the candidate because we want to think about surgeons as being decisive and really technically good. So this next category is one that I've really spent a lot of time working in, which is visibility and mentorship. That table right there that I'm sitting with represents the firsts of their type in their country. And some of them I started working with as students. So one of the women is the first woman pediatric surgeon. One is the first peds cardiothoracic surgeon in her country, general surgeon, and orthopedic surgeon. So to be able to have interactions with other women really influences and helps them sort of come through. I would not be standing here if it wasn't for male surgeons. Men can absolutely also mentor and help in this, just like I mentor and help male surgeons. This is not a gender. You have to have gender equity on both sides. We can all help. But we do know if the students see women, they're more likely to choose the field. And sponsorship is really critical. And who do we tend to sponsor? You tend to sponsor people you know. Kind of hard not to talk about family life. I'm the proud mother of 3 dogs. So I'm never the person to talk to about trying to balance family life. But boy, even balancing 3 dogs can be hard. So in the US, about 1/3 of our women have children in residency, most delay it. I just saw in the paper today that the age of first birth in the United States is the highest it's ever been. It's now 30. People are really delaying childbirth. A lot of people worry about this. They worry women disproportionately. When are they going to time a pregnancy? Can they get pregnant? Men don't tend to respond that they worry about this. In Africa, most people have children even in medical school or during their training, and they have concerns about the impact on that. How are they going to handle it? How do you handle the rotation? There are huge maternity policies. And when they're too generous, if you have a 1-year mandatory after birth maternity leave, you have reentry problems then because you haven't operated in a year. So there's a lot of things to consider here. And needless to say, we know that men are less likely to have spouses with full-time careers. Women end up missing work for their family and actually also end up taking care of both children and elder parents or sick people in the homes. This was just published literally this month. And this was a international training program. But I actually thought when you look at it and you think about how do we impact our field, people worry, our trainees are worrying about their training atmosphere. How are they being trained? What's the delivery? Not just the content, but how are we behaving towards them? And this goes to both males and females, the influence, kind of how are their careers going to progress and what's that lifestyle look like in their future roles. So these are all areas as we think about expanding training that could really help us kind of frame the challenges that both women and underrepresented in medicine people can face. So hard to talk now without talking about COVID. COVID had a massive impact on global health. There's an estimate there was 15 million excess deaths. So we know the deaths people counted, but when you compare death rates from one year to the next, you can actually calculate this excess deaths. I think the toll on the health systems has not really been calculated yet. What toll has it had on surgical health systems? We know that you've got less staff, less resources, fewer procedures in many settings, and delays in presentations and worse presentations. It did have a differential impact on women, and basically women left the workforce because somebody had to stay home with kids. It has definitely had a impact we're going to be feeling for a number of years. This was just a report that came out on the gender impact in the East and African area, and again, substantial. I feel really proud that in the States, we have tried to work very hard to make surgery a more welcoming place for women. So our first woman president of the College of Surgeons was 92 years. Dr. Schulich talked about how as president of the Halsted Society, it took 93 years to get a woman president. I was the first. And you can now see fairly rapidly, we have had and continue to have women representation at our highest professional levels. This is an amazing picture that just did not exist for many years. This is a picture of all of the women who are chairs of surgery in their department now in the United States, and the ones who have been former chairs. And we now even have surgical deans. There aren't many deans of schools of medicine that are surgeons. In Africa, it's amazing. All the deans are surgeons. Because being a surgeon is very prestigious. Here, of course, we usually have internal medicine, pediatrics, and other things. Very few deans are surgeons. And there are very few women surgical deans. So Dr. Kibbe just became the dean at UVA. There are a few other deans out there. And you can see here that the number of female deans in schools of medicine is also increasing, but kind of sitting there at that 20% number that we kind of have seen in a lot of these. So I was supposed to talk about how do you build capacity for education in low and middle income countries. And the number one thing is academic partnerships. Your department engages in this. You can help not just with institutions, help with colleges. How do you help? You can help provide training. Laparoscopy is just really coming into many areas in Africa. So helping train in laparoscopy is a great need. You can help with curriculum. All these new students, all these new programs, they actually need cases and teaching tools, and it'd be great if there was a uniform curriculum that every school could have access to. Their faculty need professional development, as do their residents, right? You need opportunities. And it's really great that you're hosting faculty for those things, because it's an incredible thing to have these exchanges. So we've hosted faculty from our sister site in Zimbabwe, and we send our faculty there. It's really, these partnerships really can be very helpful. Also, leadership growth. Leadership opportunities. So the college now is having people from low middle income countries come and have opportunities at the American College of Surgeons in leadership training, and also research. There's a huge kind of lack of training and research in a lot of low and middle income countries. And it's also the way a lot of us keep our satisfaction in our own professions. I really like to try to put the focus on how can we as academic institutions help, and not on what do we want or need. I tell our residents when they want to go overseas and do cases, I actually don't care if they ever do a case overseas, because it's not about the cases. It's about seeing a different health system, about seeing how problems are approached, how do they organize things. Their health systems need to train their residents. They don't need to train our residents. We should be training our residents. I think we also have to recognize what we can learn from our partners. One of the biggest things that I recognized when I started working overseas is how much we waste. The amount of waste in our operating rooms. I'll tell you, when it drives me crazy. How much do we throw out at the end of the case? How many extra sutures did they open for you? And when you work in places where patients have to actually buy their own sutures, or you have only a few sutures, you really learn that we could learn things from our partners. We could also learn how to do great physical exams, because when you can't CAT scan everybody, it's really amazing what you can diagnose on physical exam. We need to actively support trainees through mentorship and education. We need to encourage women and students, not just here, but also wherever. We need to address this discrimination and really kind of continue to educate on this. And I really think that gender equity in surgery, if we're going to double our workforce, which we need to do, we have to engage half of the population. And that should be a department, a specialty, and a society goal for all of this. So I hope I've convinced you that the number of surgeons that is necessary, we really have to increase this because our populations are growing in disease. We've got to put women into the field. Status quo is not an option. We do not have enough surgeons in this country right now to take care of our population, let alone in other countries. And I think societies and colleges really need to lead the way. So I'd really like to thank you for the invitation. And I want to recognize what I've seen you do in this department for the last 10 years. It has been an unbelievable growth in expertise, research, and really representation. And you really deserve a huge amount of credit for doing that. So thank you for this invitation.
So, Dr. Wren, thank you so much. That was an awesome talk. And we were actually strategizing last night about, this and that. How do you think people will react to this and that? And I think that if you look at American surgeons, Dr. Wren has done more to move the ball in terms of increasing education and standard of surgical care in Africa than anyone else. And you can just tell how passionate you are. You've been doing this for decades, even before it was a popular thing to do. And I know that you've had to make choices in your career, right? You get to go this way or that way. And you've always taken the high ground and have done sometimes at the time unpopular things, but you did the right things. And I think you need to be applauded for that big time. So we have time for a couple of comments and questions. Please, Katie.
Thank you for that thought-provoking talk. So I was fortunate enough to serve on a study section last year for NIH's increasing data science capacity in Africa. And I've actually received funding to train statisticians, or non-statisticians, but training people to do statistics in Papua New Guinea and Uganda and Mozambique. But I feel like there's a lack of funding for research in surgery globally. What is your opinion? Is that going to change, and where do you seek funding for your research?
Yeah. Do you want me to repeat for the online
Yeah,
people?
that'd be good.
So I think the question was about what's sort of the climate for increasing surgical funding, both domestically and abroad, and where have I found funding? I would say after COVID, I think the outlook is not very good. I think COVID is going to erase a lot of the gains we were seeing. So much has had to be diverted into COVID response. And when you look at even just here in the States, people who missed measles vaccinations and things like that. So globally now, yeah, I think we're going to see a resurgence of infectious diseases. So I think we're going to see money get diverted more into that. It's interesting that you say, I keep on trying to put some papers out. We had a paper in JAMA Network Open that looked at cancer funding for surgery compared to the other, chemotherapy or radiation. Just trying to keep on hitting at this, like we need to engage in funding for surgical diseases. Where do I get my funding? It's really interesting. I wrote for the American Surgical Association, we wrote a series of papers about global surgery, and I wrote the one on appointment and promotion. And one of the things that we put in is that you have no special path to be in so-called global surgery for appointment, promotion, and tenure. But the one area is in the dollar amounts of money that you can get for your funding. The most funding I have ever received for anything I do is a $150,000 grant. There's some people who've been able to get like some training grants, T32s. And there's a guy, Peter Kingham at Memorial Sloan Kettering, who has a U grant for colon cancer in Nigeria. It has been very difficult and very far and few between. Fogarty has some grants, but again, the bulk of the dollars. And this post-COVID reshuffling, I don't know what's going to happen. So, and I cannot believe you were training statisticians in Papua New Guinea. I've been to Papua New Guinea. I know most people can't say that, but I actually have. Yeah, that's very interesting.
Dr. Neal?
Yeah, one question, I guess, is you had talked a lot about trauma as being a big problem. A lot of places you mentioned is conflict, and obviously talks about force goes there. What's the role of social media to get the word out? We've seen a lot of that. The war in Ukraine, making people recognize what actually happens, what sort of victims these people are, sort of trying to move the narrative a little bit away from COVID towards that potentially. Do you think that's an avenue and an option? I also remember Kuyama telling me that when he did talk about borders, there was a lot of limitations to what you could talk about and what you did afterwards. So he couldn't publish things like that.
So for the online audience, sort of thoughts about social media, trauma, conflict, and some questions about Doctors Without Borders. So I'll cover the Doctors Without Borders first. It has really two missions, and the second part of the mission is actually to bear witness to what you see. So I would not say that you are restrained to publish, just like any other publication. You do actually have to go through a IRB type of approval. So I would say that's no different standard than anything that we have. Ukraine has been, it's been very interesting for me. So part of my weird life that people don't know about is I actually have a substantial research interest in humanitarian care in conflict zones. And my big grant right now is actually trying to make a kind of a indicator score for being able to use for quality improvement and prediction and things like that. So this is an area I've been very interested in for a number of years. The war in Ukraine, I think, again, for some people who might be old enough, the last war that was in our living rooms was Vietnam. And I think one of the biggest mistakes that was made was making the wars in Iraq and Afghanistan basically invisible to the American people, because war should be painful. We should actually see what war looks like, because to make a decision to go to war should always make people have pause. The social media aspect of the Ukraine, I find in some ways fascinating, because I think that, again, this is my personal opinion, I think that we actually see a lot of bias in the fact that people who look a lot like us are getting blown up. When there's a war in Ethiopia, there's a war in Yemen right now, there are so many other places. There was a war in Syria. So what Putin is doing in Ukraine, he took his playbook from Syria. bombed more than 500 hospitals, decimated healthcare, targeted civilians. How did we welcome Syrian refugees into Europe and the United States? Were we opening our houses like we are to Ukraine refugees? So I actually have, I mean, war is bad wherever it is. So I'm actually very conflicted in that I think it's great that people are seeing this, but in some ways, I am very worried that there is kind of a inherent bias because of where this war is, that other wars aren't getting attention, or conflicts aren't getting the attention that they should. What's really interesting, the vast majority of injuries, though, in low and middle income countries are actually road traffic generated, not war injuries. So if we could solve road traffic, and the open tib-fib fracture is the bane of your practice in this setting. RTAs.
Road traffic accidents.
Well, yeah, crashes now, well, they keep changing the word, because
really?
accident meant something, now isn't it RTCs?
I don't know. I'm getting old.
Yeah.
So I know there were a couple other people who had questions. Dr. Stewart, I'm sorry, we're out of time, but catch Dr. Wren at one of our conferences coming up. So immediately to follow in the Freeman Conference Room, there'll be a global surgery roundtable. And then, so that'll be from 8 to 9, or whenever we get there to 9. And then from 9 to 10:30, we have a case conference that will be run by Dr. Del Chiaro. Dr. Wren called this, it's a stump the chump session last night, right? So, please come by and participate. Dr. Wren, I apologize. This is probably the second one of these that you are.
Different color.
Oh, awesome. That's good. But some of the things inside may be the same, and I apologize for that. And there's something in the mail too. Thank you. Thank you. That was awesome.
How do you eject on this?